Greetings and welcome to our 48th Town Hall. Today our subject is a very interesting one that I know we'll have a lot of people interested in, that's women's health. Now you'll probably notice online that the program we're using is a little different. All the interaction will ultimately be the same using this. Unfortunately today we're also having some server problems and so most of you will be watching this taped, and we appreciate that. We've actually used the program before. It works just fine, so we'll sort that out and be back live for our 49th. With us today on set here, we have Dr. Pedro Ramirez, who is the chair of our Department of Obstetrics and Gynecology, and we have Dr. Kathleen Borchardt, who is one of our wonderful obstetrician gynecologists. She can tell you how busy she just was over the last couple of days, delivering many, many babies, as she was telling me very recently. A little mini baby boom going on around here, and just delightful to have each of you here. So we're going to start with Dr. Ramirez, who's going to talk about the department that he took over about 18 months ago, his vision, and where things are going within the department.
Well, thank you so much, Dr. Boom, for the invitation. It's really a pleasure to be here for the town hall, and certainly it is a pleasure and an honor to present to you some of the details regarding the progress that we have been making in the Department of Obstetrics and Gynecology over the last year and a half. I wanted to start with the department mission. Our mission is to be a leading global center of excellence in women's health, committed to providing innovative, compassionate, and multidisciplinary comprehensive care, advancing science, and certainly training the next generation of healthcare leaders in obstetrics and gynecology. We're also extremely proud of the fact that this year we were ranked number 14 in the country as a Department of Obstetrics and Gynecology from last year's ranking of number 25 in the country. In fact, actually, over the last 10 years, 2024 was our highest ranking as a department nationally by U.S. News & World Report in obstetrics and gynecology. So we're extremely proud of this achievement, and certainly we thank all of those in the department who have contributed to the success of this ranking. Just telling you a little bit about the field of obstetrics and gynecology and the structure of our leadership within the department. Obstetrics and gynecology as a field encompasses a number of different subspecialties, including my own. I am a specialist in gynecologic oncology, and in gynecologic oncology, we treat all of the cancer-related issues with as it pertains to cervical cancer, uterine cancer, ovarian cancer, and any other related cancer of the gynecological tract. In addition, in our department, we are very proud of our division of urogynecology. And in urogynecology, this is the division where specialists will treat a number of issues related to pelvic floor dysfunction, urinary incontinence, and related issues to the gynecological tract as it pertains to the urinary and gynecological tract as well. And of course, obviously, we have a division of obstetrics and gynecology, general gynecology. So we're very, very proud of the opportunities that we have for our patients to have their care in both obstetrics and general gynecology in our department. In addition, we have a number of leaders within the department who have led some of the great initiatives that I'm going to tell you about and share with you in the next few minutes. We're a department that, of course, obviously encompasses a number of different campuses across the region. Currently, we have a total of 46 obstetrician gynecologists, as well as 6 gynecologic oncologists and 6 urogynecologists, providing this type of care throughout the region in Houston. In addition to that, we have a partnership with Texas Children's Hospital for maternal fetal medicine specialists. These are specialists that deal with high-risk obstetrical issues. And we also have a partnership with CCRM for our care and reproductive medicine. So we're extremely proud to be able to offer these services throughout the region in the Houston area. We're also very proud of our trainees, and of course, as I mentioned in our mission for the department, one of our goals is to be able to train the future leaders in the field of obstetrics and gynecology. And in fact, we actually now have a residency that encompasses 20 total residents here at the Houston Methodist Medical Center and at St. Joseph's Hospital. In addition to that, we're also extremely proud of the fact that we will soon, starting in 2025, we're going to open our new residency program in the Willowbrook campus, and we're really very, very excited to welcome many new outstanding candidates to our Willowbrook campus in that residency program. In addition, as you see, we have a fellowship, which is additional post-residency training for urogynecology. We're the first fellowship in Houston in urogynecology, and certainly we're very, very proud of the job that our urogynecologist and the leadership on that division is doing to expand that service as well. As I mentioned, we're really extremely proud of an outstanding group of residents here at Houston Methodist, and we certainly value the care that they provide to our patients here and at the St. Joseph's campus. In addition to that, we are also very proud of the fellows that we currently are training in urogynecology and reconstructive pelvic surgery. In terms of our facilities as it pertains to the Department of Obstetrics and Gynecology, we have a childbirth center here in the Houston Medical Center, 22 beds in labor and delivery. We have our own operating room for obstetrics and gynecology here in the medical center, and we have an obstetrics emergency department as well for our obstetrical patients, as well as a gynecology and a urology unit. In addition to that, we actually saw over 160,000 patients system-wide in the service of obstetrics and gynecology, and here at the medical center, over 45,000 patients in the last year. So again, we're very, very proud of the trust that our community places in our services in obstetrics and gynecology. I want to just take a few minutes to share with you some of the patient care initiatives that we have implemented over the last year in obstetrics and gynecology. One of the issues that we wanted to particularly target, because we certainly feel it is very important to set our metric and provide the highest level of quality care for our patients at Houston Methodist, is to evaluate and determine what are the rates of surgical site infection and how we can potentially decrease those rates of surgical site infection. So to that end, we implemented a surgical site infection prevention bundle, which is a multidisciplinary initiative where we have a number of parameters that are followed in the preoperative, intraoperative, and then the postoperative care of our patients to see a significant reduction. And in fact, we're very proud of the fact where we have seen already a marked reduction in surgical site infection just within a year of implementing this program. In addition to that, recently we also implemented what is called an Enhanced Recovery After Surgery Protocol, or an ERAS protocol, that is specific to obstetrics and gynecology. We're extremely proud of this initiative, and what this entails is a number of strategies in the preoperative period, intraoperative period, and postoperative period, so that we will be able to see our patients recover much sooner. Ideally, see our patients return to their normal daily activities much faster after surgery, even after major abdominal and pelvic surgery, so that our patients get back to their functional daily activities and then get back to their families and their jobs. And certainly we're very, very proud of the implementation of this program, which is not only an implementation here at the medical center, but also an implementation across the system. In addition to that, we have recently implemented what is called a maternal task force. And this task force is aiming to evaluate what are our initiatives as it pertains to issues related to obstetrical and maternal care. So obviously we're looking very closely at our C-section rates and how we can potentially and safely reduce C-sections in our patients, reduce the length of stay for our patients who are delivering along all of the regional sites, reducing the readmission rates, and then targeting other issues such as hypertension management during the maternal care. So this is a task force that is evaluating all of these metrics, so we will ideally see an improvement as well and continue to develop strategies to provide the best care for our patients. Research and innovation is another area and a domain that is significantly important for our department. We have established a robust research support team, and with that we have expanded on the number of trials that we now offer our patients. Just a year ago we had just under 5 trials that were offered to our gynecologic oncology patients, but now we have over 16 trials that are offered to our gynecologic oncology patients. So this provides an opportunity for our patients to receive the most innovative care, both surgically and therapeutically. In addition, we're exploring options for evaluation of artificial intelligence in helping us determine the ideal patients to undergo what is called tumor debulking surgery in advanced ovarian cancer. We're also looking at the use of circulating tumor DNA so that we will be able to ideally target the best management for our patients after they complete their initial therapy in ovarian cancer. And we're also using artificial intelligence to develop strategies to improve patient education platforms. So we're really very excited about these initiatives. And then lastly, I'd like to close with one of the next initiatives for our department, in the fact that we're looking at evaluating the possibility of developing a women's wellness and care center, where we will provide the basic primary care for our patients, gynecologic and breast care, as well as pelvic health and mental health and well-being. In addition, there will be an opportunity for our patients to gain advice and counseling as it pertains to nutrition and wellness, menopause and midlife health, sexual health, and integrative medicine and holistic medicine. Lastly, I'd like to close with what are our strategic priorities for the department. We want to continue to recruit top faculty to our department, not just here in the medical center, but across the region. We want to continue to foster faculty development, to grow research and innovation within the department, and continue to enhance and support the training and education, and ideally in our field to implement a fellowship in gynecologic oncology, and ideally also an international gynecologic oncology fellowship. So I want to thank you for your time and your attention. And now I'm going to turn it over to Dr. Kathleen Borchardt, my partner, who is going to speak to you about a topic that is really important and relevant to many of you in the audience. And the title of her presentation is, Yes, It Is Your Hormones.
Thank you, Dr. Ramirez. You know, one of the reasons I picked this topic is looking at the questions that you have sent in. This seems to be something that is on everyone's mind. As far as, the way I'm going to break this down is what is normal, what are the expected transitions of your hormones, talk about menopause hormone replacement therapy, and some lifestyle modifications that you can do to help. I want to stress that this isn't a comprehensive discussion about menopause because this is such a large topic. I'm just taking one little piece of it. But I want you to know that if this is something that you're worried about or struggling with, definitely go see your gynecologist about this. Don't wait till your well-woman exam because this is such a large topic that it takes sometimes multiple visits or enough time dedicated to help tailor your treatment to what you're experiencing. So the first part I'm going to talk about, as many of you remember, the hormone changes that happen during puberty, but let's kind of talk about what happens during the fertile years. And this is important because it'll help you understand what you're experiencing as you go through perimenopause. And what happens during the fertile years, these symptoms tend to get worse as women enter into their 40s and as they transition into menopause. The two main hormones we're looking at are estrogen and progesterone. And if we zoom in on this area, you can see what happens on a monthly basis. Every month, a woman receives a large surge of hormones to help her ovulate. After ovulation, she has a high level of progesterone for 2 weeks. If she is not pregnant, then the progesterone level falls and the whole cycle starts over again. So when someone comes in and says, something's off with my hormones, it probably is. Every single day of the month, your hormones are at a different level, and so it can be really hard to be on uneven ground and to feel like a different person every day. I want you to pay attention to the large surge in progesterone because that's what makes women experience a lot of the symptoms. So effects of elevated progesterone. This is generally called PMS, premenstrual syndrome. I kind of hate that term because it makes it seem as if this is something wrong with it, but there's nothing wrong with it. This is a normal part of what happens every single month. Over 300 different symptoms are associated with this high level of progesterone. Physical symptoms include bloating, lethargy, breast tenderness, and this happens because the progesterone slows down your gut, leads to water retention. It actually affects your kidneys and your renin, angiotensin, aldosterone system. And there are psychiatric changes that come with it also: insomnia, anxiety, mood swings, and depression. And this is because the neurotransmitters in your brain are actually changed by the amount of progesterone that you have and the change in withdrawal from hormones. 15% of women report that symptoms are severe enough to cause some type of impairment or special considerations in their life. And then a small subset of women, about 8% of the female population, will have an even more severe form called premenstrual dysphoric disorder that will lead them to seek even more treatment. So treatment for kind of the spectrum of symptoms. Yes, there are prescriptions. Stopping ovulation with birth control pills is one of the mainstay treatments. Using a selective serotonin reuptake inhibitors to affect the serotonin levels in your brain can help minimize some of these symptoms. Using timed NSAIDs, non-steroidal anti-inflammatories, can help with some of the physical symptoms women feel, as well as diuretics, since this affects your renal system also. As far as non-prescription treatments go, a big mainstay of this is diet. When patients come to me and they say they're not feeling well, and I talk to them and I say, okay, well, tell me about your exercise, tell me about your diet, most people's responses, sheepishly say, oh, they both could be better. But we are, greatly affected by this. I've listed some of the things that can help, especially during this luteal phase, which is from ovulation to your when your cycle begins, when your progesterone is high. And this includes extra B vitamins, increased vitamin D and calcium, increased magnesium, as all of these can have an effect on your serotonin levels and can help minimize some of these symptoms that you're feeling. As far as expected transitions go, so let's look at this next little part. Perimenopause happens in the 2 to 7 years prior to menopause. It's characterized by irregular menstrual cycles and symptoms getting worse as hot flashes and night sweats. As you can see, our hormones don't go down in a nice linear fashion. It's kind of a roller coaster. So you can feel very different, any given month, any day of the week. Menopause is a clinical definition. It's 12 months without a cycle. The average age in the U.S. is 51. 5% of women will be greater than the age of 55. Early menopause, which is less than age 40, is associated with smoking, shorter cycles, not having kids, type 1 diabetes, and a family history. Let's see, effects of the decreased estrogen, because that's the big thing that women feel as they go through menopause. The physical symptoms include hot flashes, forgetfulness, night sweats, skin changes, thinning hair, loss in breast tissue, vaginal dryness, headaches, urinary symptoms, and then psychiatric symptoms. And I choose that word carefully because these are actual changes that are happening in your neurotransmitters in your brain that you do not have a control over. This includes depression, sexual dysfunction, insomnia, and decreased libido. Long-term effects of decreased estrogen include osteoporosis, arteriosclerosis, atrophy of the breast and vaginal tissues, and an increased risk of Alzheimer's. All right, so let's talk about menopause hormone therapy, and this is a very careful word choice also. This is our new term as opposed to hormone replacement therapy. Hormone replacement therapy makes it sound like there's something wrong. You're deficient in something and we have to replace it. But menopause is a normal transition, and so we want to help support you through this time, but there is nothing wrong with going through menopause, and just like any stage in life, it's just going to be different. For menopause hormone therapy, we like to focus on decreasing symptoms, and this usually happens with estrogen. Estrogen can carry increased risks to a patient for endometrial cancer, so we have to pair it with progesterone to protect the endometrium. If someone has had a hysterectomy, they can be treated with estrogen alone, and there are some newer options of estrogens plus a selective estrogen blocker to help decrease women needing the extra hormone of progesterone. Recommendations are to start the lowest dose for the shortest amount of time, usually around the 10 years around menopause. They should not be started for prevention of health conditions, and contraindications, of course, include any estrogen-dependent cancers, history of stroke, heart attack, unexplained vaginal bleeding. So a big question I get is about the Women's Health Initiative. Almost every woman was put on hormones in their late 90s, and then after this report was released in the early 2000s, the rate of hormones went from 22% down to 5%. And part of this was because a lot of information came out about increased risk of stroke and heart attack. As you can see, this is, if you want to zoom in, the number of women per 1,000 for 5 years of use. And when you look at the actual real risk of getting a blood clot or a stroke, they're very small, and there are some benefits, including decreased risk of fractures, decreased risk of breast cancer with estrogen only, improved overall mortality. And if you zoom into the big picture, if you look at how many women benefit and have decreased hot flashes and vaginal atrophy per 1,000 per 5 years of use versus the absolute risk, you can see that the vast majority of women are helped with a very small percentage incurring an adverse outcome. So revisions to the Women's Health Initiative, I won't go through all of these points, but as we keep re-looking back at the data, we keep coming up with kind of new stratification of the risk. A lot of these hormones that were used in the studies aren't our mainstay treatments anymore, so we're not sure how much we can use that data and extrapolate it to the hormone use now. But the big thing that we took out of this is that the timing matters. We should start it around menopause and not wait until you're in your 60s and 70s, as the Women's Health Initiative allowed. So starting it when you start having symptoms around perimenopause is the safest time to start it. We should try not to continue it past 10 years. And there are some overall health benefits to it. But for each individual patient, it really has to be tailored to their individual symptoms. Does the hormone formulation matter? A common question I get is about bioidentical hormones. I do want to stress these are not FDA approved. These are done in compounding pharmacies. You don't know exactly how much you're getting. I'm not opposed to them or patients using them, but I do think that we have so many FDA approved options first that we should try those where we know the risks and benefits prior to going to the bioidentical. When it comes down to it, they're both using the same hormones. They both come from the same hormone manufacturers. It's just kind of how they're prepared. Transdermal is the safest form, so you might notice that your gynecologist has tried to get you off of your oral hormones and switch you to a patch or a gel that you rub in, because we know that there's not an increased risk of blood clots when we use transdermal hormones. And the progesterone that we used in the Women's Health Initiative is not our mainstay treatment of progesterone anymore, so we do think that there is safer forms of progesterone that we can use now. Non-hormonal treatments for vasomotor symptoms. So many of our patients who have breast cancer are not a candidate for using hormones. We can use SSRIs. Soy has been used to help decrease with symptoms. Relizin is a Swedish pollen extract that we use in our cancer patients that helps reduce vasomotor symptoms, as well as another SSRI. And then this was the position statement from the North American Menopause Society. It's called NAMS, and this is a good website to go to. It's now just called the Menopause Society. So if you're looking for extra information, if you're looking for a practitioner who is certified in menopausal medicine, this is where you would go, that they have, this is our great resource for this. As far as painful intercourse goes, which is a very common symptom, prevention, so using vaginal estrogens and creams can help rebuild the collagen in that tissue that we lose after menopause, as well as using daily moisturizers and lubricants during intercourse. Other options include CO2 lasers. I kind of joke with patients about the vaginal estrogens. It's like a skin serum. You can't use it once and look younger. You have to continue to use it to notice the difference. As far as vaginal estrogens go, we have some really big studies that have come out that our cancer patients can use these. So if you think that these were never an option for you, there's a very low systemic absorption level from vaginal estrogens. And so especially if you're through that window and into remission and you're suffering from vaginal dryness from maybe chemo or radiation, these are a reasonable thing to use, but it does need to be a multidisciplinary conversation. As far as low libido goes, there's many things that contribute to this. Mood and anxiety disorders, as well as medications you might be on for those, can help decrease your libido. And the main thing that causes libido when in your fertile years is a spike in androgens that help you ovulate. So when you stop ovulating and you stop having that spike in androgens, it is normal. Your body has shifted away from trying to focus on procreation. And so this is a normal thing that kind of happens. As far as low libido goes, addressing relationship issues, family issues, social issues, it's tough because at this point in your life, a lot of patients are caring for aging parents. Their kids are starting to leave the house. They're dealing with other medical disorders, starting other medications, and so there are so many factors that can contribute to this. As far as treatment for low libido goes, we do have one FDA-approved option. This does need to be taken for 8 weeks before we can notice a difference. It helps about 50% of patients. There is a black box warning that it can drop blood pressure and it can't be consumed with alcohol. And then we have some off-label treatments for low libido, including testosterone. This is, I think, very reasonable to use in patients after we've tried our other options. I know we've received some specific questions about testosterone use in women, and this is an option. Also increasing norepinephrine, which can be done with certain types of medications and exercise, as well as being aware of medications that decrease serotonin levels. For improved sleep, this is a big part of menopause. Also, sleep hygiene is so important, and there's just so many topics I want to talk about with menopause. And another big one that I didn't get on here is exercise. Women lose 3 to 8% of their muscle mass every decade after 30, so it is so important to not only focus on that zone 2 level workouts where you elevate your heart rate for a sustained amount of time, but resistance training, weight training, building muscle mass as you lose it, as well as balance, because all of those become so important. All right, I think that was all I have for you today. I know that was a lot to take in, and like I said, this is not a comprehensive conversation about menopause, but I do want you to know that there are so many reasons to explain what the changes you're feeling, and I can't emphasize enough that if something's bothering you, please go talk to your gynecologist, because there are so many things we can do to help you.
Well, thank you very much, Dr. Borchardt. Okay, well, I want to follow up on a couple of questions. Obviously, the field of hormone replacement, as you talked about, or hormone therapy, it has gone all over the map. It's one of the most confusing things for people, I think, because obviously many of the people who are watching today, kind of grew up in an age when everybody they knew was kind of automatically getting on it. It was this big deal, keep them on it for life, and then it was, no, don't do any of it, and now it seems like it's a little bit in between. Can you put a finer point on that a little bit in terms of, the average, I guess, woman who comes to see you having some menopausal symptoms, how you approach that, and then maybe the average woman who is in her 50s and is going through menopause but maybe not that symptomatic, and might you treat them differently in that case? Right,
so the big focus should be on treating the symptoms. So if someone is completely asymptomatic, there's no reason to start hormones, and that is our kind of governing body's stance on this, is that we shouldn't use it to treat long-term conditions.
So that's really big difference from the way it kind of used to be. Which is everybody should be on it.
Especially there was a really big study in the 80s that they put every single woman on hormones because they thought it would decrease cardiovascular risks. And they actually found, and then the pendulum swung the other way, and so it does kind of keep going back and forth. I think that the vast majority of patients that are in good health could benefit from hormone replacement therapy to ease the symptoms, ease the transition, and also give them some support during that time. Now, I do have plenty of patients who are in good health. Maybe they don't have a uterus and they could stay on estrogen the rest of their life. But this is a very individualized conversation.
Okay, so for most women, asymptomatic, you're probably not going to offer anything. Having symptoms that they feel need management outside of many of the non-drug therapies. You'd be, if they have a uterus, you're talking an estrogen progesterone combination, and are you saying you do that basically for a time period in which they're symptomatic to ease through that?
Correct.
No longer than 10 years.
Yep.
Is what you're saying.
Instead
so
of going through.
You wouldn't see many 70-year-olds on hormones at this point in that scenario.
So I do have a fair amount that are still on it from previous generations, and they're doing great, and they're staying on top of their health checks, and so it can be reasonable to continue them, but we should not start someone in their 70s on hormones.
So you're having those conversations obviously on a case-by-case, individual by individual, and talking all the pros and cons and other things. So, okay. Well, that's very, very helpful. I know there were a few questions coming in around testosterone therapy. What are the downsides?
So the downsides to testosterone therapy is really in the formulation that it comes. When we're going to do testosterone, we want to use the transdermal form and do it very slowly and incrementally increase it. We do worry that since it's not studied in women, there could be an increased risk of some cardiac implications. What I don't love is the pellets that give you a really high dose of testosterone that slowly wears off over 3 months. Because if a patient does encounter an adverse outcome, they cannot take it back. They cannot remove it out of their body. Things that we see with too much testosterone is a deepening in voice, increased hair growth, especially on the chin, clitoromegaly, where we see actual physical change in the genitals from the testosterone. So it is a medication that we have to be careful with.
So there are some downsides with that. Okay, great. And then one last question that had come in about hormone replacement was specific. Let me just put a finer point on this. After somebody who's had a total abdominal hysterectomy. The question about how long should it be there, and obviously you don't need progesterone, as you were saying before. Right?
So since estrogen doesn't carry the same risks as progesterone, and the difference is if you have a uterus, you have to stay on progesterone. If you don't have a uterus, you can be on estrogen alone. If someone is in good health and the estrogen is helping them, I am very comfortable continuing patients on this for decades.
And that comes back, obviously the uterine part, but that also comes back to all those side effects that the long-term study was showing in terms of Women's Health Initiative, where it's higher with estrogen plus progesterone, or therefore the progesterone than with estrogen. Is that right?
Correct.
Got it. Okay.
So we don't carry some of those same risks with the estrogen alone.
So then you feel much more comfortable saying let's do long term. Okay. Well, great. Well, thank you. Dr. Ramirez, I want to ask a couple questions here that came in also. Can you talk a little bit about mental health programs that are offered specifically for women, and areas of concentration that might focus on that are obviously unique to women, like postpartum period, menopausal period, and others. So.
Yeah, well, thank you so much for bringing this question and this topic to light. Certainly we consider that mental health, and particularly related, as you mentioned, to maternal mental health is critical, and it's really very, very important to assess, evaluate, and potentially treat if this is the case. It is a very common problem, and certainly one that we're now developing strategies and initiatives to actually have a mental health specialist, a psychologist, within the Department of OBGYN, actually have someone where our patients will have an opportunity for direct referrals, rather than having to go outside of our institution. So we're in collaborations now with the Department of Psychology to potentially actually have not only a staff psychologist, but also possibly a fellow dedicated to maternal mental health. So we're really excited in that. I really hope that we'll be able to bring that forth in 2025.
Okay, fantastic. And I noticed one thing in your slides, to switch gears back to some of what you're talking about and really all the quality initiatives. You showed an image of an article on the surgical site infection bundle.
Yeah.
If one looks at that article closely, the lead author at the listed last, I think, was a certain Pedro Ramirez. Am I right?
That's right. So
tell us a little bit more, because that's obviously very impactful nationally.
Yeah, we're very, very proud of this initiative, and as we all know, obviously, surgical site infection is one of the metrics that we look to determine the quality of care that is provided to our patients. So we really wanted to make sure that we had a set strategy and a structured strategy for our services, not just in gynecologic oncology or general gynecology, but also now extending to obstetrics as well. And the goal with these initiatives is to develop a multidisciplinary team, and that's really critical and important, that this is a focus not just on surgeons, but also bringing in the nurses, the preoperative nurses, the clinic nurses, the anesthesiologists, the postoperative nurses, to all come together and cohesively come up with a strategy as to how each of those domains will contribute to improving the outcomes of those patients. So that publication, we're extremely proud of that publication, because it was one of the first publications that I had here with our Methodist team, and it really outlines what we actually did and what were the implementations of that surgical site infection bundle and the steps to follow. So this has been an article that now frequently is requested by some of the leadership in quality and safety at our regional sites, and actually nationally as well, where they look and say, well, what's the formula at Houston Methodist? How can we follow that? And just to end with an example of the fact that when we look at our metrics in obstetrics and gynecology, from the beginning of 2023 until we started this program in November of 2023, we had a total of 7 surgical site infections. Since November of 2023 until now, Friday will be 1 year anniversary of the implementation, we have had 1.
Wow.
So it's really impacting, and we're very proud of it.
That's great. And it's multidisciplinary. Does it involve some preoperative steps from the patients and postoperative steps? So
yes.
Where's the patient's role in all of that? Because that's relevant to any real surgery that we have.
Yes. I'm glad you highlight that, because the patients are critical in the success of the implementation. There's a great emphasis on patient education, so that the patients will understand the benefit of these implementations and these initiatives. And in fact, actually, it's very encouraging to see how patients actually take ownership of really being an integral part of the success of this. And we're just very, very proud to see that they want to take part in their own recovery and speeding up that recovery and reducing their infection rates.
That's great. Well, thank you. And I want to shift back, because there's some other questions around screening and wellness and other things, specifically around part of a well woman exam is obviously thinking about breast care and breast cancer screening risk, and a question specifically about, should I be just getting standard mammograms? Should I be requesting something more? I hear about ultrasounds, I hear about 3D mammograms, these kinds of things. What do you do as a OB-GYN who cares for women who are coming in and asking those questions?
Well, to break it down a bit, a traditional mammogram is where the breast is compressed and an x-ray is taken. The 3D mammogram actually moves the sensor around so that you get a better drawing or 3D picture of the breast. An ultrasound is using it's an ultrasound and it's looking for fluid pockets, and it can check for different things than an x-ray can. And MRI is the kind of another step that can look for densities, it can look for blood vessels, and no one of these tests is superior, but they all work together to look at different things. The standard of care now is to get a 3D mammogram, and you'll have noticed recently on your mammogram reports that you might see that it says women with heterogeneous or dense breasts should have a ultrasound to aid in the detection of breast cancer. Now understand that some of these statements, this was made by law that this has to go on all mammogram reports now. About 40 to 50% of women have heterogeneously dense breasts, and so they will qualify for a screening ultrasound with their screening mammogram. It's a little difficult because insurance hasn't quite caught up yet, and so the diagnostic mammogram is usually what we order, which would encompass the 3D mammogram plus the ultrasound. So that's what we're ordering for most patients. Now, Methodist, we have started to do screening ultrasounds for patients, and we have these at most of our community locations where a woman can go and have her screening mammogram and a screening ultrasound done at the same time. So it is important to talk to your doctor about what your risk factors are, how dense your breasts are, what did the radiology report say the last year, and to make a good plan of what would be the best imaging modality for you. Because a patient with high risk for breast cancer, they should be getting MRIs every year also. So really trying to individualize, what do I need?
And kind of going with that, and I'll follow on with a couple other screening tests as well, but picking up on mammography, is there now a synchronized recommendation around the time to start? Because there's different societies and different things.
We have a difference between American College of OB-GYNs, the American Cancer Society, the U.S. Preventative Task Force. They all have a little bit different recommendation. And I do think it's important to talk to your gynecologist about what your individual risk factor is. If you're someone with a high risk of breast cancer, you should be starting at 35. You'll see some organizations say not till 45 or 50. I truly believe that every woman should start at age 40. They should have it done yearly, and you'll see recommendations to stop at 70. But the vast majority of my 70-year-olds, they're in great health, and you should continue mammograms as long as you're in good health, and that if you found a cancer, you would treat it. If at some point in your life you get where if you found something you wouldn't do anything about it, that's when you can stop screening.
So that was the other part of the question, is when do you stop?
Yeah.
And I mean, I see this a lot. I have a very small clinical practice. Many of my patients started with me when I first got here, so we've all aged together a little bit, let's put it that way. So, we have a lot of questions about, do I keep doing this, do I not keep doing it? And my rule of thumb has always been exactly what you said, which is if you're otherwise healthy and we would do something about it, of course we should find it, right?
Absolutely.
So the recommendations either fizzle out at 70 or 75 usually on most of these metrics. So a similar question, colonoscopy, since you end up doing primary women's care as part of this. Somebody asked that question as well. What do you do in terms of how long you do that?
Well, so a big change has been to move up colonoscopies to age 45 now, since the risk of GI cancers are increasing in the U.S. But same thing, as long as you're in good health, I think it was the way they word the studies is that they don't know if there's a benefit to mortality after 70, 75. But we shouldn't just be looking at mortality, we should be looking at quality of life, being able to treat a cancer, and that's why if you're in good health, continuing it and discussing with your doctor if it's reasonable to continue, because if you find something, would you do something about it?
The good thing there is if you don't have stuff that they're removing, you get a nice 10-year recommendation.
Exactly.
In the 70s, you probably are not going to need to do it again after that. And then maybe a little more complicated question is about Pap smears, and is it possible to stop doing Pap smears at some point?
Yeah, so the big difference in Pap smears is our technology is better. They used to just scrape the cells, put them on a slide, and say, do these look precancerous or not? Now those cells are tested for the DNA that causes the virus, the HPV virus. And so if a patient that causes the cancer,
yes,
so we're actually can test the cells of your cervix. Do you carry the virus that's going to cause cancer? And so at age 65, if you've had 10 years of normal PAPs without the HPV virus, it is reasonable to stop testing at age 65. Now, stopping the PAP doesn't mean stopping your well-woman exam, and it does not mean stopping your pelvic exam. We still need you to come in every 2 years so that we can look for vaginal and vulvar cancers, as well as do a checklist of symptoms and do a bimanual exam with our hands to check for abnormalities in the uterus and ovaries.
Okay, that's really very helpful for a lot of people here, I know. So,
And
if
I may just add also,
Yeah.
I think it's important to highlight that for the patients who have had a recent or past diagnosis of cervical cancer, that may be different because obviously they need to continue following with every 3 month Pap smears for the first 2 years, and then every 6 months for the next 3 years, all the way up to 5 years from that diagnosis.
Very helpful. And so kind of that segues a little bit into your realm, of course, is in gynecologic oncology. But I'm asking a broader question that of which I know part of it will be this answer, which is what are the biggest women's health issues over age 65 that we deal with? Obviously, we've talked about some of those in terms of some longer-term hormonal therapy and things, but talk a little bit about what those issues are.
Sure, and I think certainly there are several, and it's very, very important for women to be aware about those issues. Cardiovascular disease is, I think, one of the most prominent. And of course, obviously, with that related elevated blood pressure, elevated glucose, and potential higher risk of stroke as well. So it's very, very important for women to follow up with their primary care physician. Osteoporosis naturally is one of the other main issues, and particularly also obviously leading to potential fractures, which can be very debilitating for women over 65. Type 2 diabetes is a major problem here in the United States. Of course, obviously cancer, and it is important to follow with the recommendations on screening as recommended. And also particularly mental health also becomes an issue with all of the related issues that Kathleen discussed as it pertains to a change in the structure of the family, caring for other family members, and all of these elements. And sometimes, of course, obviously, as the children leave and the family disperses, there may be issues related to increased higher risk of depression. So I think it's very, very important for women to be aware of these issues and be able to discuss these issues with their primary care physicians or their OBGYNs.
In terms of any other issues to think about, let's drill down a little bit on osteoporosis that you talked about. How do you all screen for osteoporosis?
So I do always like to remind patients that bones used to always be on the gynecologist plate, but now we have a very specialized endocrinologists who help with osteoporosis. But as a general rule, most women should start with a bone density, which is our screening process to see if you have low bone density, at age 65 and every 2 years after that. Women that we should screen sooner is if they have a strong family history of osteoporosis, a personal history of fractures that were non-traumatic, if they're on any medications that could also lower their bone density. So it might be very well appropriate to start much sooner. And this is where exercise comes in, vitamin D, calcium, so important through the menopause transition to be preventative.
Okay, great. And what are the things, you talked a little bit about this, but not even needing all of that therapy someday, trying to avoid getting osteoporosis? What are the risk factors? And then how do we try to even tackle that? And what age should both men and women, but we know it's more prevalent in women, should we be thinking about that? Yeah,
so we actually see a large decrease in your bone density starting before you go have your final menses. So in your 40s is when a big portion of your bone loss can happen. So this is why it's so important in that kind of perimenopausal area to being on vitamin D supplementation. Calcium, we think, is better absorbed through diet, and so making sure that that's a focus of your diet. But weight training and resistance exercise are so important during that time.
You gotta use those bones. Right?
Yes, you have to use those bones. Exactly. And so don't get me wrong, swimming is great, and cycling is wonderful, but they don't necessarily put the stress on your bones that you need to help keep them strong.
My primary care nag will come out again, which is every single one of these things we talk about. Well, how do you prevent it? It's It's always exercise, it's
I
watching
know.
your weight, it's eating well, it's
know.
sleeping well, and that's because it's true.
Yeah.
It's important in all these things. So, well, one last question for each of you. I got a question that had come in ahead of time around the dangers of untreated fibroids. Can you talk about that? And associated with that, I want to ask you a question around other cancer screening, particularly we get cervical, we talked about that, and you talked about vaginal and vulvar, but uterine cancer, ovarian cancer,
Yes.
how do we screen for those? And because they're obviously something many people fear.
Yeah, so I'll start with the latter part of the question. With regards to cervical cancer screening, we talked about with regards to the frequency of Pap smears. For endometrial cancer and ovarian cancer, we don't have a set test as we do for Pap smears and cervical cancer. For endometrial cancer, which is the most common gynecologic malignancy in women in the United States, certainly one of the very important and key elements is for women to be aware as to what the symptoms are. And typically it presents with women having postmenopausal bleeding. So if a woman has already entered her menopause, but starts having irregular bleeding, irregular spotting, regardless of the frequency, it's very important to go see their physicians. It is a type of cancer that often is very easily detected by an endometrial biopsy, either in the office or in the operating room. But it's critically important that patients are aware that these symptoms may indicate a potential precancerous or a cancerous
So
lesion.
if you've gone through menopause, there's no level of bleeding you would have that you go, oh, it was just a little bit. You come in and see your doctor at that point, right?
Absolutely is key. And that's a very well articulated, because it's exactly that. Any level of bleeding should initiate a visit and a discussion with a physician. Now, as it pertains to ovarian cancer is not the most common, but certainly is the most deadly, because it's often presenting with advanced stage disease. And often when we talk about ovarian cancer, we hear from patients and many times physicians that, well, it's a type of disease that doesn't really have an associated symptoms. But in fact, actually, it's been found that women who are diagnosed with ovarian cancer typically will have about a 6 to 9 month period prior to the diagnosis where they were reporting to their physicians, I have increased bloating in my abdomen, something's not right, my diet has changed, my bowel habits have changed. So when a postmenopausal patient starts having all of these symptoms, it's very important not to dismiss them as just a natural process of aging, but in fact actually to seek the help of the physicians. Now, to the point of the question on the fibroids, and I'll also let Kathleen provide input. From the perspective of cancer, many patients are worried about, will my fibroids potentially turn into cancer if I don't do anything about them? The likelihood of a fibroid turning into a malignancy is less than 1%. So it is exceedingly unlikely. And the one sign that may potentially direct us to think about a fibroid turning into a malignancy is when there is a documented very rapid growth. So that would be the one signal
kind of
that we would say.
a warning.
That's right.
Or
That's right.
a higher risk situation. I
That's
guess.
right.
Okay. And thank you. That's very helpful. I'm going to ask one last question, which is that came in also, which is around racial disparities, particularly around maternal health, and if you could give us some thoughts around what we're doing around that.
Yeah, so I love that our department is addressing this, and we know that 80% of maternal mortalities are preventable, and a large portion of those in women of color are cardiac. And so when you have to have a very low suspicion of threshold, especially early in care, to establish care with cardiology for these patients and to watch them very closely. But another aspect of this is preeclampsia, which is a high blood pressure disease of pregnancy that sometimes and often we don't have any warning on. We're piloting a program called Baby Scripts, where patients will be able to do remote blood pressure monitoring. They actually can take their blood pressure by Bluetooth. It'll go into their app and it will come to our office for us to review it. And this will we know that preeclampsia disproportionately affects women of color, and our hope is that we can find signs and symptoms of this sooner in our patients, address it sooner, and hopefully have better outcomes.
Okay, well, great.
Yeah.
Well, thank you for that. Okay, well, I'm going to wrap things up here, and thank you both. I'm going to give you a rapid fire update on a couple of things happening at Houston Methodist, since we had a robust conversation there. But give you a couple of updates. One, just to update you, some of you may have been reading about this in the news. It certainly made our lives a little interesting. We're managing this, and our team's always are just so great at managing challenges and in a very multidisciplinary fashion, very similar to what we've been hearing with obviously our clinicians at the forefront, but all the administrative people, supply chain and others. And the issue is that Baxter, which is a manufacturer of IV fluids, some of you may remember back in Hurricane Maria, they had issues when a plant got taken out in Puerto Rico. Well, their plant in North Carolina, which actually Baxter provides 60% of the intravenous fluids for the United States, not all at that plant, got knocked out by Hurricane Helene last month. And ironically, one of the sort of improvement things they had done after Hurricane Maria was to say, you know, we need a stockpile of IV fluids that are available in case we have a hurricane or another natural disaster. Well, they stockpiled it all in the North Carolina plant, so the stockpile didn't help either. So what ended up happening with that is they put all hospitals in the United States, and they changed back the pediatric to normal, but all on 60% allocation. I say 60% because we have yet to get 60%. We've been getting less than that each time. Now, we had some inventory. We always keep, you know, obviously some inventory on hand. The government's gotten involved as allowing importation, and they are doing so. Actually, they've also allowed use of or extended the expiration dates. You remember they did some things like that during the COVID crisis as well. Those are done very thoughtfully by the FDA in very safe fashion. Frankly, there's not a whole lot of out-of-date inventory that helps with that issue. And thankfully, this week, that plant's coming back online. So far, this has had minimal impact for us in terms of our ability to do care. There's a few procedures that use massive amounts of normal saline as irrigation, like 15 or 20 liters in a procedure. So we've had to curtail a few of those just because obviously they use so much in a shortage situation. But outside of that, we've been able to manage through a lot of great work from our clinicians and others. You really look at strategies not to waste. You look at oral rehydration instead of IV hydration. You look at preoperative care and really modern science today, which would say you can be drinking clear liquids for most people and most procedures up till a couple hours before a procedure. Many things like that. We can get by on 60-70% supply. And what I've been just warning everybody, hey, if Baxter doesn't deliver on what they've said they'll deliver on, it may become an issue, but I don't think it will be for us because of the great work of all these teams and because this is starting to come back online, and we think by the end of the year they'll be at 90 to 100% allocation, and we should be doing well with that. Just to run through a few happier topics, we were just one of only 24 health systems in the country where when WebMD took a look at preferences in a city, we were more than 2 to 1 over a competitor, and that only happened with 24 institutions around the city. You heard about a lot of our great work around a culture of safety and quality here from Dr. Ramirez. We celebrate that each year. We actually have our employees and physicians and others nominate projects and colleagues and other things and celebrate those awards. I want to call out Dr. Stuart Dobbs. Some of you may know Dr. Dobbs, who's been the Chief Quality Officer at Houston Methodist Hospital here, the medical center, really the father, and people were saying even grandfather of our quality programs here, who has now or is now stepping down and will be Associate Chief Quality Officer and passing the baton. And so we spent a lovely time honoring all of his tremendous contributions. We're very active in the community. United Way, we raised over $320,000 through our employees. Many things through our I Care in Action program. We give every employee 8 hours of PTO on an annual basis to use with a pretty long approved list of charities. We also have some very specific ones where we go out. This is a picture of many of the people a couple weeks ago rebuilding a home and fixing a home. I'm very proud of what they've done. And then just to point out a couple things, you know, this whole series started on COVID and a pandemic and infectious disease. And as we talked about then, it's really a call to action where we are driving our infectious disease activities into the status of a center of excellence, of which we have 6 others right now. And we continue to drive in that fashion. Here you see 2 very large multi-center trials that we are now part of. One on the herpes virus and really looking for vaccines to help prevent herpes, and the other being preparation for future pandemics. So if you read this, this is thinking about vaccines for lots of stuff that maybe as physicians we learned about in infectious disease and we never think about or hear about all the time, but where we're always afraid could jump into humans, become the next pandemic. And so we're a big active part of that and very proud of that around the country. And then on that topic of vaccines, this was actually put out for our employees and others because we have a mandate here, and we were one of the first institutions in the country to mandate flu shots, so that's why you see the October 31st date. But you're in the sweet spot if you have not gotten your flu vaccine. We definitely recommend you get your flu vaccine. The other question I get a lot, in fact, I got it at our board meeting last week, and like literally a day later, we got some revised recommendations from the CDC, which were similar to what I was telling them, which is if you are in a high-risk group, immunocompromised, over 65, the CDC recommendation now is twice a year COVID shots. So look back at when your last shot was, look back at when your last infection was. Think about, when you want, pragmatically when you might want some antibodies running around, like if you got big travel coming up or other things where you want to be particularly protected. We're actually at a very low point here in Houston right now. The pattern has been the same every year, and literally was trading notes yesterday, a text with the head of the Houston Health Department, and we're both predicting in the next couple of weeks we're going to see the wastewater coming back up because we've seen that pattern every year. So right about now, next few weeks would be the sweet spot of time, I think, to protect yourself for the holidays, for the winter, etc. And if you are in one of those groups, every 6 months. And with that, we'll wrap things up, and we look forward to seeing you next time.